So good evening, everyone. My name is Ashwin Venkatesh. I'm the Educational Lead for NANSIG. Welcome to the third installment of NANSIG's new webinar series, Neurosurgical Career Insights, where we aim to provide medical students and junior doctors with an overview of what a career in neurosurgery entails. So previously, we've covered introductory talks on what is neurosurgery and the principles of neurosurgery, and you can find these on our YouTube channel, as well as this video today. So today we intend to explore in more depth the subspecialty of paediatric neurosurgery. And to that end, it's my pleasure to introduce Mr. Martin Tisdall, who is a consultant neurosurgeon at the Great Ormond Street Hospital in London, where he serves as the lead for the Children's Epilepsy Surgery Service and the surgical lead for traumatic brain injury, which are his areas of clinical expertise. Mr. Tisdall also holds a position as Honorary Senior Lecturer at the Institute of Child Health at UCL. His research explores clinical outcomes from epilepsy surgery, imaging techniques for pre-surgical assessment of children with epilepsy, near-infrared spectroscopy, and multimodality monitoring of cerebral hemodynamics and metabolism. We're very grateful to Mr. Tisdall for offering to speak to us today. As usual, just a few housekeeping tips before we begin to minimize any disruptions. Please could you all remain muted and have your webcams turned off at all times. And please direct any questions to the chat function and I'll create a list for our Q&A at the end of the talk. That's it from me, and thank you everyone for joining this evening. Over to you, Mr. Tisdall.
Okay, Ashwin, thank you very much for the introduction, and thank you for the invitation. It's great to be here and look forward to it. So I'm just going to share my screen. Hopefully you can all see that. So as Ashwin says, I work at Great Ormond Street Hospital. I'm a consultant paediatric neurosurgeon. And I've been a consultant since 2013. I think the first thing I'd like to say is it's great to see paediatrics near the top of your list. I think if you look in any general neurosurgical textbook, you'll see that paediatrics is always relegated to the back. So it's great that we're getting in there early. What I'm going to do today is talk to you a little bit about paediatric neurosurgery and what we actually do and what the subspecialties are that we cover. I want to talk a little bit about what perceptions are of paediatric neurosurgery, and then really where those perceptions go wrong and what the realities are. And I want to concentrate a little bit on what the key differences are between paediatric and adult practice. And then because I hope that all of you are interested in careers in neurosurgery, I thought we should talk a little bit about what sort of people may be suited to a career in paediatrics and then what the training pathway looks like. And hopefully we'll have some time for some questions at the end. Just talking to Ashwin, I assume that you will have some level of neurosurgery and what it entails. So I'm going to talk across the subspecialties, and I think the first thing to say is that paediatric neurosurgery is a subspecialty in its own right, but actually as you get into paediatrics, and if you spend your life working in paediatric neurosurgery, it then divides up into sort of subspecialties. I'm very lucky to work at Great Ormond Street, which is the largest paediatric neurosurgery centre in the UK by quite some way, and what that case volume allows us to do is to really dive deeply into what are quite rare subspecialties or subspecialties with quite low numbers of patients. And one of the great strengths of the NHS is that through the commissioning process, which is essentially how the government decides to pay hospitals for the work that it does, it sets up a process where rare diseases are treated in centres of excellence, and therefore you concentrate volume, and that allows the doctors to gain experience and improves outcomes. So I hope that these subspecialties mean something to most of you. You'll obviously notice that these are all conditions which one will see in adult neurosurgery, but there are some sort of nuances to in paediatrics in terms of clearly the sort of size of the patient that you're treating, but also in terms of the pathologies that we see in each of these subspecialty areas. So I'm going to talk briefly about each one of them and just go through the list here as you'll see. So hydrocephalus is an interesting place to start because probably about a third of the work we do in paediatric neurosurgery relates to hydrocephalus or to fluid CSF disturbances in the brain. And that's a far higher percentage than you would tend to see in an adult practice. So I think it's fair to say that no one can be a paediatric neurosurgeon without becoming very au fait with hydrocephalus. One of the things that I'll come to later is that a lot of the time we are treating children with chronic health conditions who will keep coming back again and again. So whenever you operate on a child, you need to be thinking not just about what is needed today, but what's going to be needed tomorrow, over the next few years, and on and on. As I say, I'm a paediatric only neurosurgeon, so actually I transition children at the age of 18 to adult partners. But many paediatric neurosurgeons in the UK have a mixed adult paediatric practice, and that means that they would treat children from birth all the way through their life. And so it's very important when you're thinking about how to manage some of these conditions that you think about the future. And so I put this picture up here, which shows a patient who has a complex hydrocephalus with multi-compartmentalized system and has had multiple catheters placed into fluid systems in the brain. And I put this in a way as a sort of cautionary tale. These sorts of situations are a bit of a nightmare when people keep putting more and more catheters into the brain. And just to think that we need to be very aware about always trying to make the system simple, understand exactly what's going on, and not just treat the problem that's directly in front of you, but look to the future. Hydrocephalus, as many of you will know, often involves treatment with endoscopy or the management of hydrocephalus by putting cameras into the brain, with the classic operation being something called an endoscopic third ventriculostomy, which is where a perforation is made in the floor of the third ventricle, which is this structure here. And this again is a slight difference in paediatrics, that we tend to see more of this obstructive hydrocephalus, and endoscopy is sort of seen as one of the key skills of a paediatric neurosurgeon. This is just a picture that you tend to see in the third ventricle, and some of you may know that this is mammillary bodies at the back of the floor of the third ventricle, and this is the area, the very thinned out area in the floor of the third ventricle, where we look to make a stoma to allow CSF drainage to bypass an obstruction. The next area I wanted to talk about is neuro-oncology, which again, I'm sure will be familiar to a lot of you. And I think the important thing to say here is that children have a different set of sort of oncological problems. They present with different tumours. There is a much higher percentage of posterior fossa tumours, which are quite rare in adult practice. They actually don't make up the majority of paediatric tumours, although a lot of people think erroneously that they do, but they probably make up about 40% of the paediatric neurosurgical oncology cases. Treating neuro-oncology, or certainly treating malignant neuro-oncology in adults, can be quite a depressing thing to do. There's a high predominance of GBM, glioblastoma multiforme, which still has a very poor outcome, with most people dying over a period of 1 to 2 years. Paediatric neuro-oncology, even for highly malignant tumours, is much more positive. It's still a difficult condition to treat, but the long-term survivorship is much, much higher. And I think it certainly makes it a much more optimistic place to work than adult neuro-oncology. The next area I wanted to talk to you about was trauma, which again will be familiar to most of you. And I think one of the big issues of trauma in paediatric neurosurgery is thinking about safeguarding and non-accidental injury. And really, in any child who is referred to a neurosurgery centre with trauma, one needs to be asking the question, could this be non-accidental injury? Because we have a duty of care to the child to ask that question. You can see here a 3D reconstruction of the skull, showing a fracture here running from the midline into the parietal area. Remember that in the child, the skull is often growing, and so the sutures of the skull are open, particularly in the early stages of life. This shows the anterior fontanelle. coronal suture, sagittal suture, and metopic suture, and then this fracture. And I guess it's important because when you're trying to analyze these sorts of studies, you need to know what is normal and what's abnormal. And if you don't have that knowledge, you might be mistaken in thinking that there were multiple fractures across this skull. Coming back to the, so I would say that the vast majority of head injuries that we see are actually quite minor head injuries in the modern era. And certainly there's been, I think, a big reduction in significant head injuries in children, which relates really to things like road safety, wearing helmets on bikes and such like. To give you a bit more of an idea of the safeguarding question, it is obligatory for any child under the age of 2 who sustains a head injury to have a safeguarding assessment and to be reviewed by a paediatrician, to do other investigations if needed, and obviously take a history. And so I think that's something which is quite particular to paediatric practice. One area of subspecialization which is not really seen at all in adult practice, or very rarely, is that of craniofacial. And craniofacial work is disorders of the shape of the skull. And that can relate to the cosmetic appearance, which is very disfiguring and can be very important in terms of how people are treated in later life. But it's not only cosmetic. There are significant issues related to airway management, related to exposure of the eyes, and in particular related to raised intracranial pressure, which require quite complex management and a multidisciplinary team approach, which brings together primarily neurosurgeons, but together with plastic surgeons with a specialization in craniofacial abnormalities. And these two specialties work together and operate together to try to manage these problems. Just to give you a bit of information about this is one of the more severe forms of craniofacial abnormalities that we see, and this is described as a cloverleaf skull, which is almost invariably related to syndromic craniofacial abnormalities. And you can see these sort of tripartite bulging laterally, and then this sort of superior bulge as well, with this constricting band around the skull, which leads to this characteristic appearance. If you look at the CT, you will see that there seem to be holes in the skull. Obviously, these are the orbits here, but looking at the skull, you see this sort of copper beaten or Lukenschadel appearance, which is often associated with raised intracranial pressure. And for those of you who are looking closely, you will see, or you may be able to see, that there is a ventricular peritoneal shunt placed here. As I say, raised intracranial pressure is a major problem in this group of patients, and not infrequently they would end up with ventricular peritoneal shunts to manage their raised intracranial pressure. This sort of work is managed through a few units only in the UK, because it is so specialised and requires such large groups of experienced doctors who have seen a lot of this work, and Great Ormond Street is lucky that we're one of those centres. Spine, again, something that, spine is a very large part of adult neurosurgical practice, but the type of abnormalities we see in paediatric practice are quite different. You can see these very sort of significant spinal deformities associated with spinal cord compression. And again, these often require a multidisciplinary approach with team working between neurosurgeons and orthopedic spinal surgeons, so that these sorts of areas can be not only decompressed to make space for the spine, but then they can be fixed with metalwork, as you can see in this central picture here, where the orthopedic spinal surgeons have come in and placed fixating metalwork to stabilize the spine and to prevent further deformity in the future. And then I put this picture over here on the right, which shows congenital spinal dysraphism with a cervicothoracic myelomeningocele. And you can see the spinal cord herniating through a defect in the dura, and then in this case, what looks like a skin-covered CSF-filled cavity, which requires repair to prevent it eroding through the skin and then having problems with CSF leakage and infection. And one of the other reasons I put that up here is because this is a congenital abnormality, and one of the big focuses of paediatric neurosurgery is that actually we are often treating congenital problems rather than more of the acquired problems which you might see in adult practice. Spasticity was the next area I wanted to cover. So these slides show an operation known as SDR, selective dorsal rhizotomy. And this is an operation that is carried out for children with cerebral palsy who have spasticity in their lower limbs. And by selectively cutting sensory nerve roots in the cauda equina, we are able to reduce the spasticity in the lower limbs and to help them with their walking. And this is something which has really become more popular over the last 5 years or so. And it was initially sort of not available on the NHS unless parents were able to pay. But over the last 3 years has now become available, commissioned by the NHS. So that's a huge step forward for these children and their families to allow them to access this type of surgery. And you see here the way the operation is done with the dural spinal covering opened up and the nerve roots exposed. And this here is a stimulator which we're using to stimulate the nerve roots, to check the levels and to check that they're sensory roots, and to work out which of these roots should be sectioned to provide best outcome. The next area I wanted to talk to you briefly about was neurovascular. So in adult neurovascular practice, the main component of neurovascular neurosurgery relates to aneurysms and to ruptured aneurysms. In paediatric practice, the case mix is quite different. Aneurysms in the paediatric group are actually very, very rare. We do occasionally see them, but they often relate to underlying sort of soft tissue, connective tissue disorders. In children, there is a much higher sort of proportion of these cases that are made up of arteriovenous malformations. Arteriovenous malformations being an abnormal tangle of blood vessels where the capillary network has been disrupted, so you have direct communication between arterioles and venules, leading to a structure which is prone to bleeding and requires a management process involving interventional radiologists and neurosurgeons with various treatment paradigms, including embolization with glue or coils, and also open microneurosurgery to resect these abnormalities. The other thing which I don't have a slide of actually, which is gamma knife radiotherapy, which is a non-invasive technique where we use very focused radiotherapy to shrink down these lesions, and that can be very effective also. The sort of most extreme form of arteriovenous malformation is something called a vein of Galen malformation, which is an AVM into the large draining veins in the center of the brain. This is obviously an MRI, a sort of midline MRI scan, sagittal section. And this is a T2 MRI scan where blood is black. So this entire structure here is a sac of blood and leading through a very, very dilated straight sinus. This is a sort of normal structure which is present in everyone, but is hugely dilated and then feeding into the deep veins. And this is such an extreme sort of situation that these children with a severe form of vein of Galen present in the neonatal period with catastrophic heart failure. And that's because this shunting system in the head is of such low resistance that 80–90% of the entire cardiac output is flowing through this malformation in the brain, and is therefore not able to perfuse properly the kidneys, the legs, etc. And because of this low resistance, the children get into a high output cardiac failure situation, which requires management often in the first weeks of life. And this is extremely high risk. It's not, you'll be very glad to know that this is not managed by neurosurgeons primarily. It's managed by interventional radiologists who attempt to glue up the connections from the intravascular route. And again, this is highly specialised work, which is only managed in the UK, really, at Great Ormond Street at the moment. Liverpool, I should say, Liverpool Alderhay has started doing some of this work over recent periods. So again, because this is such a rare condition, it really makes sense to concentrate expertise in a small number of centres so that we can improve outcomes. Another sort of very exciting and quite new technique which I wanted to talk to you about was prenatal surgery. So we've discussed how we spend a lot of time managing congenital problems, and there is data to suggest that actually if we operate on children before they're born, we may be able to limit the impact of some of these conditions. So the first condition where there's been real steps forward with regard to prenatal surgery is the management of open myelomeningocele. And some of you will know that there is a well-known study called the MOM study, which took place in the US several years ago, which showed that in this context, we can reduce rates of hydrocephalus and something called Chiari-2 malformation in the longer term by repairing the defect in the back and the spinal cord before the child is born. And there's also a little bit of evidence that this may lead to marginally improved motor outcomes. And this is a really interesting sort of ethical debate, because by operating on the child before birth, you obviously have two patients, not just the unborn baby, but also the mother. And clearly, this is an operation which is not for the benefit of the mother, it's for the benefit of the child. So it raises a number of quite interesting ethical questions about this. And the way this surgery, I guess the underlying concept of this surgery is that you expose the child's back, and then this is a depiction of an open myelomeningocele, and you repair the open myelomeningocele and close the skin over the back, and then you put the baby back in the uterus and stitch the uterus closed and wait for them to hopefully come to term. The mothers are not allowed to go into labor, which makes sense because you have a large scar in the uterus. We do this surgery in the sort of 20 to 24 week gestational period, and then hopefully get them as far down the line in terms of lung maturation before the children are then born by cesarean section towards the end of the pregnancy. So this is a schematic of what's going on. So incision in the abdomen of the mother, identification of the uterus, and then opening of the uterus. And this is, the baby is then turned over so that the back is pointing uppermost. A sort of amniotic type fluid is infiltrated. And this is the appearance at surgery. So you can see here the uterus, which has been incised. This is the baby in the uterus, and this is the open myelomeningocele, which will then be repaired, and the uterus will then be stitched up, and the abdomen will then be stitched up. And so again, this is very rare work. This is highly complex work. This requires a very large team of doctors and surgeons, including fetal medicine, including obviously obstetricians, and including neurosurgeons. And you will see that there's a bit of a theme coming here, because again, I'm saying this is not just neurosurgery. It involves lots of other people working together. It's the sort of work which we're very lucky at Great Ormond Street to have been commissioned to do. At the moment, NHS England has commissioned Great Ormond Street and actually a centre in Belgium, which is in Leuven, to do this work. And we are working in partnership with them. And again, are able to build up this experience by taking referrals from all across the United Kingdom. And there is scope for other procedures to be done in the prenatal period. So outside neurosurgery, there is a range of procedures which are done, often relating to airway problems, which are obviously particularly important around the time of birth. That makes sense. But there is now some discussion in the literature about how other forms of dysraphism, such as encephalocele, might be best operated on before birth. And so I think it's fair to say that this is an evolving field, and it's a growing field, and we're very pleased to be at the forefront of this in the United Kingdom and working with international partners. So this is epilepsy surgery, which I've left to the end because it's my subspecialty interest and something that I'm very passionate about. And epilepsy, in a way, is something that we really should be sorting out in the paediatric period. The vast majority of adults who have epilepsy will have developed epilepsy before the age of 18. And in a way, if as a paediatric neurosurgeon I was doing my job properly, I would put the adult epilepsy surgeons pretty much out of business. We know that epilepsy carries a very large chronic health burden with regards to obviously the whole issue of having seizures, but on top of that, deterioration in IQ and cognitive development associated with chronic epilepsy, but also things like psychiatric disturbance, which is highly overrepresented in children with epilepsy, as is autistic spectrum disorder and other behavioural problems, and also the social stigma of epilepsy and having seizures. And we do a very sort of wide range of things in epilepsy surgery in children, going from very large operations to very small operations. And I thought I'd just give you a little sort of snapshot of that, and really just looking at some of the work that I've been doing over the last month, just to give you a sort of an idea. So this is a little baby who's 3 months old, weighs 6 kilograms, and has intractable epilepsy, which has been present from birth, with a seizure frequency of hundreds of seizures a day. And when you have that volume of seizures, it impairs cognitive development to such a degree that these children are not really able to learn anything. So they're not really developing at all. They're not learning to fix and follow with their eyes, to sort of look at things, and they're not really interacting. And if they don't get treatment with this sort of catastrophic epilepsy, they will never really be able to get any useful cognitive development. So this child has a condition called hemimegalencephaly, where in this case, the left hemisphere has grown in a completely abnormal way, and it affects the whole of the hemisphere. And you can see that the left hemisphere is overgrown. The midline is shifted by the bulk of brain tissue on the left-hand side. And on the right, you see this normal gyration and sulcation, which we see on the brain, whereas on the left-hand side, we see very coarse gyration and a very sort of abnormal structure. And this child requires an operation called a hemispherotomy, where we disconnect the entire cortical surface of the left hemisphere. And this is a post-operative MRI scan which shows how we've done that, sparing the deep grey structures and the thalamus, but have performed a disconnection around this. And this is a major challenge, and sort of shows some of the issues that we have in paediatric neurosurgery. This child, as I say, is 3 months old. They're very fragile. They have a weight of 6 kilograms. This is a very long procedure, including the anaesthetic time, takes about 9 hours. The total blood volume in a child this size is less than half a litre. I'm sure most of you will know that we often say if you lose 25% of your blood volume, then you start to go into shock. So that means that as a surgeon, you have 120 mils of blood to play with in the context of a very fragile brain, which is hypervascular because of seizures. And you can see that this is a major, major challenge. So, I mean, obviously we have, very, very expert anaesthetic teams, and these children do get transfused. So I wouldn't say that their blood loss is necessarily less than that, but I'm just suggesting that it doesn't take very long for you to get into trouble if you start to sort of fail to have meticulous hemostasis. So a lot of the challenge of this sort of operation is actually trying to maintain control and navigate your way around what is a very, very fragile and often sort of edematous and hard to manipulate brain. On the other end of the spectrum, we do very minimally invasive surgery as well. And this is a condition which really, again, is very much in the sort of zone of paediatric epilepsy surgery, which is hypothalamic hamartoma, which is a abnormal mass of tissue growing adjacent to the hypothalamus and often located in the third ventricle. And one of the things we've started doing recently, this is a procedure we've started at Great Ormond Street over the last year, I guess, and we're the first centre in the UK to perform this procedure for hypothalamic hamartoma, either in adults or in children, actually. And this is a laser ablation technique where a laser catheter is placed into the hamartoma under sort of stereotactic guidance, and then we're able to heat the laser in the MRI scanner and directly measure the heat of the brain tissue as we do that. So this is obviously a looped video which is showing heat emanating from the tip of the laser. And on the right-hand side, you see the yellow pixels of the damage map, which essentially is a sort of mathematical construct of where we believe we've destroyed the tissue. So by using this technique in an MR-guided fashion, we can grow that destructive area to the size of the hamartoma. And by measuring the temperature of the surrounding tissue, we should be able to avoid causing any damage to sensitive structures such as the hypothalamus, optic radiation, pituitary stalk, mammillary body, etc., which are in this very small and quite sort of eloquent area. And this is a technique which was developed in Texas in the US. It has to be said probably about 10 years ago now, but has only been CE licensed for use in Europe a year ago. And something else, again, where we are taking referrals from all around the country for this very rare condition. And we're lucky enough to be able to provide this at the moment on a charitable basis because it's not yet fully commissioned by the NHS. And this is the sort of final appearance that we see. So again, damage map superimposed on the MRI scan. You can see here there's these two black dots just behind the hematoma, which are actually the mammillary bodies, which we saw earlier in that picture of an endoscopic third ventriculostomy. And these are part of the memory circuit, so they're very, very important for us to preserve. You see here the catheter down through the brain, and this is a post-operative or post-ablation MRI with contrast, which shows the area that we've ablated, highlighting with contrast where in the area where the blood-brain barrier has been disrupted, and this is the final damage map. So just to sort of show you the two extremes of paediatric epilepsy practice, from the sort of very large operation to very small operation. I just thought I would also show you a case study before we move on to sort of more general conversation, because I think this is another, I was sort of looking through cases that I've done in the last month, and I thought this was a particularly interesting case in terms of the way that we went about it. And I thought it would be it does highlight some of the aspects of paediatrics. So this is a child who came in the middle of October, came in at the beginning of October, 18-month toddler, completely fit and well, and then presented with a 1 week history of fever and coryzal symptoms, was given some antibiotics and was sent home, and then came back into hospital more unwell. At that stage, grew this bug called Kingella from blood cultures, and presented with seizures at that stage, and ended up getting intubated. So initial study was a CT head, which showed a bit of hemorrhage here on the left-hand side, and this sort of subtle hypo-intensity on the right-hand side, suggestive of a stroke. Because of the blood cultures, the child went on to have an echocardiogram, which showed endocarditis with a vegetation on the mitral valve and a degree of mitral valve regurgitation. And the child was started on intravenous antibiotics, which is obviously standard treatment for infective endocarditis. Now, the issue here is that the intracranial pathology is almost inevitably caused by septic emboli, so small septic debris coming off the vegetation and being embolized into the brain, which will obviously cause problems from an infection perspective, but in a way, more importantly, are blocking the arterial inflow and causing strokes. And if you have an unstable vegetation, then that is likely to continue, that process is likely to continue. So the next step was for this child to have an MRI head, which they went on to have the next morning. And the MRI, so this is a T2 axial image. You can see this is the area we just saw on the CT scan on the left-hand side, which shows some bleeding on the left-hand side. But what we're now seeing is diffuse swelling of a large volume of the right hemisphere of the brain. And if you look on a diffusion scan, which shows you acute ischemia, you can see that the entire right middle cerebral artery territory has stroked out. So what we've got is an unstable vegetation that is progressively throwing off emboli. We've got bilateral damage to the brain, much more so on the right than the left. And we've got an evolving picture where the ischemia within the brain seems to be getting worse over time. So this is quite a complex condition, and I think, well, it's a complex set of conditions. And I think what's really important here, and something which seems to come up again and again if you work somewhere like right on the street in paediatric neurosurgery, there is no textbook that you can go to that will tell you what to do here. There's no real agreed set of criteria, because you have a number of problems. The management for the endocarditis which is best is to take the child to surgery and to surgically remove the vegetation and to repair the mitral valve regurgitation. The problem with that is that requires the child to go on ECMO, extracorporeal membrane oxygenation, so that's complete heart-lung bypass. And the only way to do that is for them to be completely heparinized and placed on blood thinners so that their blood doesn't clot the pumping system. That's all well and good, except for acute infarct in the brain is essentially a contraindication to heparinization and ECMO, because there is a very high risk of bleeding into the brain with catastrophic results. So you're sitting here on a tightrope trying to work out what is the best course of action for this child. And what this requires is a large number of people to come together with expertise in various areas to understand and to talk through what they feel is the best course of action. So we bring together an MDT at 5 o'clock on a Tuesday evening with a wide range of specialties involved, neuroradiology, neurology, consultants from infectious diseases, consultants from intensive care, myself representing neurosurgery, cardiology, cardiac surgery, hematology. So you've got a huge number of specialties there represented already, and we sit and talk and work out what we think is the right thing to do. And in this context, we felt that if we do nothing, this child is going to have a terrible outcome because they will continue to stroke out more and more areas of the brain. They already have bilateral damage, but the area on the left-hand side is really quite small, and we would hope that they would not have significant impact from that, although it is worthwhile to say that it's not too far away from where we would consider Broca's area to be. But this child is only 18 months and not yet speaking, and so they have ability to manage that. We also feel that in the context of an unstable vegetation, the mitral regurgitation is likely to get worse. And so really we take a decision that the only thing to do here is to proceed with what is a very high risk set of procedures, but that it is in the best interest of the child in that context. So we went ahead and did a decompressive craniectomy. So actually, from my perspective, my worry was that if there was an extension of this infarct or if there was bleeding into this area when the child was post cardiac surgery, we would be in a very difficult situation with regarding to do anything about it. So we actually did a sort of semi-prophylactic decompressive craniectomy, which means taking out a large piece of bone and doing a dural expansion, so opening the dura and stitching in a dural graft and then loosely placing the bone on top, as you can see on the CT on the right hand side. The child was intubated, and so the pressure was moderately elevated, but I think this really was to prevent problems down the line rather than because pressure was acutely raised at that stage. 12 hours later, the cardiac surgeons took the child for mitral valve repair and vegetation removal on full heparinization, and essentially we crossed our fingers at that stage for the next 24 hours and hoped that there wouldn't be significant bleeding. And, you know, we don't get these decisions right every time. Sometimes these decisions do not lead to good outcomes. But in this case, we were very lucky. This child made a very good recovery and actually was discharged to their local hospital after 4 weeks, walking up and down the stairs, anti-gravity power in the left hand, able to give a high five with the left hand, some weakness of the left arm, but already having bilateral hand use only 4 weeks after this stroke. And I think, again, one of the reasons that I put this here is it just highlights how amazing children are at recovering from this sort of thing. I mean, this is a huge stroke, which if you saw this in an adult would lead to a very, very significant functional deficit. But children have this amazing ability to sort of manage brain injury and have great levels of plasticity, and have both ipsilateral and contralateral cortical motor connections, as you will know. And so what that means is that we, you know, the level of sort of pathology that we're prepared to deal with is much greater than in an elderly adult, where you might actually say this is going to be so quality of life impairing that it's not worthwhile to do. And I think, you know, it's very, very rewarding when you can get together with a group of sort of fellow clinicians and come up with a plan which actually leads to a good outcome. And I'll talk about some of the themes that I've been bringing up in a minute, I think, but you probably will guess what they're going to be. So I wanted to move on and just talk about what's different in paediatric practice. So we've talked a bit about some of these things, but whenever you're treating a small child, you're likely to be, a lot of the children we treat have ongoing health needs. They have congenital problems. It's some children, you treat them and they go away and you never see them again. But a large proportion of the children we treat will be coming back to see you, coming back to see me until they're 18, and then we'll go on to adult partners. So as I mentioned at the beginning, they have chronic health needs, they have long-term follow-up, and all the management that you provide has to be in the context of thinking what's going to be needed in the future. Where's this all going? We do a lot of MDT working. We work with a lot of partners in other specialties, and that's partly inherent in that that group of children that we treat who have often a multitude of congenital problems and require different specialists to input into their care. This is very time intensive, and it only suits particular types of people, but it's very rewarding, and actually you learn a huge amount by working with different specialties. Often we're working in evidence-free zones. It may not be obvious what the right answer is, and you may need to sort of go back to first principles. But I think if you have to do that, then it's hugely important that you're working in a supportive team, that you can talk things through and that you can come to a consensus, because making some of these decisions on your own can be very challenging. In paediatric practice, there's a huge focus on communication. And I think this is actually one of the major differences between paediatric and adult practice, that you're not only treating the child, but you're often treating the family or carers. Probably about 30% of the children we treat at Great Ormond Street in neurosurgery are under the age of 5. So a lot of them are nowhere near being able to take responsibility for their health decisions. Some children are. Some children are at an age where they can, for example, have mental capacity, but they may actually not have the cognitive ability to have mental capacity. So you're always having to think about the parents and what they think. And it is hugely stressful for the parents to put their children through neurosurgical procedures. And some of you may be parents and may have some experience of what it's like to be a parent, but it's a massive deal. Speaking personally, I've taken my daughter for a tonsillectomy once, and I felt that was pretty stressful. So I always think, how on earth can a family give you their 3-month-old child for an all-day operation? And I think it is, the stress that they go through is immense, and you have to do what you can to try and alleviate that stress. You have to take on some of that stress, and you have to manage those families through that sort of life-changing episode for them. As I've said, a lot of the stuff we treat is very complex, congenital, and requires input from many people and involves multiple systems. It doesn't mean you need to know about all of that stuff, but you just need to work in that context and have quite a holistic attitude and know when you need other people to get involved. Pediatric care tends to be very consultant-led when compared to adult practice. And I say and delivered because a lot of it is consultant delivered, but we go out of our way to make sure that our trainees also are getting the exposure they need, but under very supervised conditions. And that again is quite different to adult practice, where as a trainee, as a registrar, you are often you're often being left to operate on your own, and that's a really good thing for you in your training. Pediatrics, the stakes are higher, and often the sort of margins for error in terms of things like blood loss are lower, and so we tend to supervise a lot more closely, and therefore care does tend to be, as I say, consultant-led and delivered. And there are operative differences, and I think this relates to things like blood volume, the fragility of the tissues, the preponderance towards things like CSF leaks after surgery mean that one has to be absolutely meticulous about dural closure, about how you close the skin. When you're looking at hydrocephalus and shunt management, if you want to keep your shunt infection rate low, which is one of the sort of bellwethers of pediatric neurosurgery practices, is what is your infection rate in shunt operations. If you want to keep that down where it should be, of the order of about 2%, you have to be absolutely meticulous about every step of the operation. I'm not saying that pediatric surgery is more difficult than adult surgery. I don't think that's the case. I just think that there are different things that you need to focus on. And certainly if you want to have a low complication practice in pediatrics, you have to be absolutely meticulous about those things, such as wound closure and hemostasis. On the other hand, actually, that one of the other things I find, that I love about paediatrics actually is that you don't have, the children are so easy to move around. They're really light. They have beautiful, healthy skin, which heals in a beautiful way. They tend not to have, lots of subcutaneous fat. The tissue planes are often beautifully visualized and open up in a much more pleasing fashion than in adult practice. So I think there are big advantages as well. Myths and realities. So if you talk to a sort of archetypal adult neurosurgeon about paediatrics, they'll say, well, it's boring. They only do shunts. No one likes shunts. There's no exciting operating. There's too much talk, too much emotion, and not enough operating. And I think, clearly I would disagree, but I know where some of that comes from. We often find that things in paediatric hospitals work a bit slower than in adult hospitals. There's often slightly less number of cases on your lists, and you do spend a lot of time talking to families and in MDTs and talking to colleagues, and you certainly don't spend all your time in an operating theatre. I would certainly have an issue with the idea that there's no exciting things that we do. I think I've shown you a bit of a range of the very sort of specialist work that we do in paediatrics. And I just put up here, some of you will be aware that last year we carried out a separation of conjoint twins, so craniopagus twins who are joined at the skull and at the brain and share blood vessels within the brain. And this is another sort of absolutely huge task requiring multiple operations, huge teams, a lot of planning, and was really, I wasn't myself involved in this set of operations, but hugely rewarding that the team were able to successfully disconnect these two twins and get them both out of hospital in a good state at the end of this. So I would say that the reality is actually we do a huge range of operations of very high complexity, not all of them, but very variable, but some very, very complex operations with a huge focus on team working. And when I say requires excellent clinical care, what I really mean is that the medical care around these children is often more challenging than in adult care because they tend to be small, fragile and unstable with underlying medical conditions. And it's one of the things that I really like about paediatrics is that it's actually not just about operative care, but it's also about perioperative care and managing quite unstable children in that perioperative period of time. I think that actually there are high levels of emotion, not within the team, but within the interactions with families and carers. And I think if you want to go into paediatric neurosurgery, you need to be able to manage that. And I think it clearly requires a real focus on communication skills. And because of that communication and because of what the families are going through, it's often highly stressful. Who does it suit? Well, I think it suits people who have a great deal of empathy and a degree of emotional intelligence. And I think you need to be very patient-centered. You need to be able to manage stress, which is true for all neurosurgery, but in a slightly different way in that you're really managing stress from patients, carers and families that is being put upon you. And I think you really need to enjoy working in a team. You need to be meticulous, as I said, when it comes to operative technique. I think who does it not suit? It doesn't suit surgeons who only like to be in the operating theatre. There's a lot of work we need to do outside the operating theatre as well. You need to be a team worker. It doesn't suit people who like to only work alone. And I think you have to be interested in communication. And you need to be able to deal with complications. I think that all surgeons have complications, but in paediatric neurosurgery, we do see quite a lot of not particularly significant dangerous complications, but we are constantly faced with little things which have not gone quite as we want. And I think actually one of the key things for being a good surgeon is having the right level of how you reflect on your complications. And I think what I'm saying there is that if you are overly emotionally involved with complications, then it doesn't actually give you a sort of objective space to reflect on what happened and to improve and to learn from what's happened. On the other hand, if you are, your archetypal psychopathic surgeon who pays no attention to complications, then similarly, you won't learn and improve as you go forward, because we need to use our complications as essential learning so that we can improve it and move forward. And I think that's a difficult and subtle line to follow, to keep yourself emotionally involved at the right level, neither too uninvolved and on the other hand not over involved. But I think with the comment about operating and the sort of the complexities of that, I thought I'd just put this quote up from Harvey Cushing, who I'm sure most of you will have heard of and is always, called as the father of neurosurgery. I would like to see the day when somebody would be appointed surgeon somewhere who had no hands, for the operative part is the least part of the work. And I think that's quite true in its own way, that actually as one becomes more experienced as a surgeon, you realise that the most difficult part is often the decision making and patient selection rather than the actual operation itself. I wanted to talk briefly about the training pathway, and many of you will know a little bit about this, but the modern training pathway for neurosurgery is via foundation training and then national selection taking place much earlier on in your career than it was for me. So national selection into a specialist registrar training post with an 8-year training program. If one wants to go into paediatric neurosurgery, then there is a minimum requirement for 6 months of registrar training as you go through your adult training block, which is not a huge amount. Obviously, the skills you learn in adult neurosurgery are all highly transferable, but to become a paediatric neurosurgeon in the UK requires you to have done an accredited fellowship program for a year, which may be a national training fellowship program or maybe international. We have a number of fellowships for people who want to train in paediatric neurosurgery, and many of us have also trained abroad, and I've been trained for a year at Sick Kids in Toronto, which is a fantastic training group and is somewhere that's been visited by quite a lot of the paediatric neurosurgeons in the United Kingdom. And that leads then to a CCT, a completion of training where one is deemed fully trained to deal with acute neurosurgical issues. And I think, I put that wording there because, in the current day and age, we would all accept that day one consultants are not fully trained. And obviously that training program goes on for the rest of your career. But the first couple of years as a consultant, one really is cutting your teeth and becoming fully independent as a paediatric neurosurgeon. And it's not expected that you would be ready for that on day one of your consultant career. So how to get your foot in the door? If you're interested in paediatric neurosurgery, I would just say, get in touch with paediatric neurosurgery centres. We're always happy for people to come and spend time with us and to observe and to see what's going on and to get a sense whether they think the specialty suits them. During foundation training, you're able to apply for taster weeks and come down and spend some time with us as a junior doctor. We're always keen for doctors for students and junior doctors to get involved with us around research projects, and we always have projects which can be on the smaller side, which can be quite helpful in terms of timing, and to work with us towards things like publications, abstracts, presentations at national and international meetings, and things like that, which will all be very good on your CV and will stand you in good stead when it comes to national selection. I just thought I'd put a quick shout out to Brain School, which is run by one of my colleagues in London. This is a neurosurgical education program run by Greg James, who's one of my consultant colleagues at Great Ormond Street, and is now available virtually, and so can be accessed by anyone who wants to, if you're on the mailing list. And if people want the details and they don't have them, I can put you in touch with the right people. And I just put my email there if anyone wants to get in touch around any of these things. And my final slide is just to say that, I think if there's one thing which characterizes paediatric neurosurgery, it is team working, and we work with a huge number of highly dedicated clinicians. I'm very lucky to work with a great group of consultant neurosurgeons at Great Ormond Street, and I think that actually really benefits the care that we provide, and also benefits us as individuals to work within those teams and to get that sort of support that one gets from working in highly functioning teams. I'm going to stop there, and I'm going to stop sharing my screen, and I am happy to take any questions that anyone has.
Mr. Tisdall, thank you so much for providing us with that overview of the subspecialty of paediatric neurosurgery and for highlighting the differences with adult practice. I think for me, you really helped me appreciate, and everyone else as well, the sheer variety of pathology that you encounter that's being matched by the advances within the subspecialty. You mentioned the importance of a multidisciplinary approach for all your cases, and the uniqueness not only of thinking about your young patients and also their carers during the present, but in considering how to optimize their future when performing such interventions. All of our attendees are hugely appreciative of the time and effort that you've put in for this. So thanks very much for joining us. And I'd also just like to shout out at this point to eBrain for sponsoring this Zoom account, without which we wouldn't be able to do any of these talks. Thank you all for joining. We'll be sending feedback regarding this webinar series to you all, and we'd appreciate your honest feedback for how we can improve. Thank you all, and thank you, Mr. Tisdall, for joining us this evening.